varicose veins topic, which is quite simple, and I feel this is the stepping stone to somebody who wants to do vascular IR. A very large number of patients, something that can be done by IRs all by themselves. Actually, if you can do a bit of wound care, then maybe perhaps absolutely all by yourself. And the point is that the diagnostics is also our, you know, strong point, and since that is where the basic thing starts. If somebody can refer you varicose vein from diagnostic to treatment, you are able to take care of the entire thing, and it can be sometimes extremely rewarding. The incidence of this disease is extremely high, and almost 20% of women in their lifetime will suffer some degree of varicose veins, and even 10 to 15% of males. It's not something which is only associated with females, but of course, slightly higher incidence. They might be at different degrees, but you will get consults. So if you are a varicose vein specialist, you will end up even getting consults for spider veins, reticular veins before they become symptomatic. You can give them lifestyle modification, you can give them compression stockings, you can give them certain medications. So all of those things are there which can be done by you alone, and that gives you a clinical setup. People start coming to you for this specific issue. And what really changed in the last 10 15 years is that the shift from surgical management to endovascular management, which has been quite drastic. And it's not only the minimal invasive nature, but because we have such better understanding, we are able to make sure that the recurrences are on the lower side. So we'll be discussing very little about the initial symptomatology and the grading, and primarily on the various modalities that we have in intervention. So once the symptoms are quite non-specific in the beginning, they can be when you don't see those veins. Sometimes if you see big, large veins, that is one definite symptoms. But people usually have dull, aching kind of pain, heavy legs, night cramps. So when somebody comes with you for pain, you should be able to differentiate whether this pain is actually because of the varicose veins, or these can be there at 50, 55 years of age, and the patient might also have associated radiculopathy. They might have claudication because of vascular issues. So you have to, or they may be joint pain, knee pain, leg pain. So if you see veins and there is pain, it is not necessarily that you directly go for the treatment, because they may not be the reason for the patient's symptoms. So the dull, aching, heavy legs that they'll complain of कि भारीपन आ जाता है. As the day progresses, it is worse. Normally arthritis and all, they'll say in the morning when we wake up, especially the inflammatory kind of arthritis, that's more, and then as we start walking, it improves. That should not happen. Leg elevation and all, you should ask, does it improve as you rest in the night, and in the morning the swelling and everything is gone? The radiation, if the patient has some veins in the lower part of the leg and he's telling pain on the lateral aspect which is coming, and some amount of back pain also, you should realize that this might be a neuropathic pain and not really related to vascular supply or the venous issue. Always do the pulses, see the popliteal pulse, see the DPA and PTA pulse. So if you are able to figure out that that's also an issue, and the patient has typical claudication type of history, that he starts walking, feels the pain, rests, and then again, he is able to walk. So you should be able to differentiate those pains. So these 4 5 symptoms: dull aching pain, heavy legs, night cramps, muscle fatigue, these are the type of pain you'll see in varicose vein. If somebody says very sharp shooting pain, suddenly एकदम दर्द उठता है और ऐसे लगता है नस पे नस चढ़ गई है, so don't get confused with that नस पे नस वाला system. That is something which is more because of nerves. Pruritus, of course, you will have discoloration and pruritus because of the blood getting deposited under the skin, and that can lead to itching. That can lead to some ulcers. If there are large bulging veins, it can lead to bleeding. Sometimes because of the subcutaneous edema, because of the swelling, if you get small injury, cellulitis can develop. So cellulitis, bleeding, ulcers, these are slightly more severe complications, while pain, dilated veins, uh, then restless legs, pruritus, all these things are the earlier phases. So now the other thing is, once you realize that the patient has varicose vein, then you should go for the CEAP classification. You should be able to write it in a manner that people understand that you are writing a scientific understanding of varicose veins. Just writing, varicose veins is not the right thing to do. You should write a diagnosis of chronic venous insufficiency, and then we try to put it in a CEAP classification. Primarily, the C staging you should definitely write. So the C staging that comes is on the clinical manifestations. So if there are some telangiectatic or reticular veins, you call it C1. Once you see varicose veins, basic criteria is 3 mm. If it's more than 3 mm, no, not in ultrasound. This is when a patient comes to you. This is a clinical situation. If you're getting a consult, so that's why I'm saying get into the intervention mindset. You're not putting your ultrasound report. That is Doppler. You will put SFJ, SPJ incompetence, perforator incompetence. That you should be able to do. I think most of us can do that part. But you also have to understand whether these veins are causing the problem or not. So you put that into clinical context. So when you have varicose veins which are bigger than 3 mm, then it becomes C2. If it's recurrence, it is C2R. If the patient also complains of edema over the day, like because of the varicose veins, by time night he has malleolar edema, and that's C3. Then once skin changes come into the picture, then whether it is pigmentation, whether it is proper lipodermatosclerosis, you have typical hardening of the calf if you've seen a few patients, and corona phlebitis is severe blue large veins. So that becomes 4A, 4B, 4C. And if you have an healed ulcer, that ulcer tha, now it is better, that becomes C5. That at some point of time, the issue has caused an ulcer, though it has now healed. And if it's an active ulcer, it is C6. And if it was something which was healed previously, you treated it and now it has come back again, then it is a recurrent active venous ulcer. So you should be able to put it in this manner. Not that it changes too much, even knowing that it's ulcer or there are certain symptoms is enough, but people will start taking you more seriously if this kind of clinical you'll write in your prescription or you write on your pad, then they understand that this guy means some business. So when you diagnose, we all know basic diagnosis after the clinical part. If you have suspicion, you have to do a Doppler. So a duplex scan has to be done. Very important, rule out history-wise as well as diagnostically the history of DVT. Because if it's a secondary reflux, you had a DVT previously and now you have a reflux and the deep veins are, chronically affected, you cannot do your procedure because you will end up causing more harm to the patient. So always rule out DVT. Even if the patient doesn't have DVT, make sure you do a scan well, do all the compressibility, check the entire length of the deep vein, and not just at one or two places, to make sure that deep veins are quite clean. Then you look at the site of reflux, SFJ, SPJ. Yeah, that's the classification, in general classification of varicose veins. So that will help you putting it into CEAP as well. But somebody asks you what is spider, what is reticular, and what is varicose. So spider is less than 1 mm, 1 to 3 is reticular, and more than 3 is varicose veins. Then you have to figure out whether the reflux is there or not at SPJ, at SFJ, and at perforators, and whether that reflux is significant or not. So significance at GSV and perforators is more than 0.5 seconds के लिए अगर there is a turn. So you can see here in this image, I'll just take the laser pointer. Yeah. So if you see these patient, this was a normal flow. Then you ask them to do a Valsalva, and this is the reflux. And if it continues for more than 0.5 seconds before it shuts down, normally in a competent junction, you'll see a blip and it then shuts down. So, but if this reflux is continuing for more than 0.5 seconds, then it is significant. Also look at deep vein reflux. That is something most of us don't see, because sometimes, even though you might have superficial reflux, patients who had previous DVT or some kind of previous DVT which is now cleared with anticoagulation also, or none, no history like that, can still have deep vein reflux. That means the reflux is not in the superficial system alone, but within the deep veins also, the blood can go opposite. The valves in the deep system are also affected. When that happens, that means if more than 1 second in the deep system you are having a reversal on Valsalva, then maybe just treating the superficial varicose veins may not be useful. So, this is the reflux. Patient is normal flow is towards the SFJ, and then suddenly when you ask the patient to do Valsalva, it goes opposite. So you see this reflux it's the change in the direction of the flow when you ask the patient to do Valsalva. So if that is for more than 5 seconds, there is a reversal of flow. When you ask them to do Valsalva, that means reflux in the superficial system. And similarly, you can also check reflux in the deep system. And in that, if you keep your Doppler and you get the power Doppler on, and you ask the patient to do a Valsalva maneuver, and if there's change in direction, normally the flow should stop at best. It should be like this, and then it should be no flow if you do Valsalva. But if you see the opposite, that flow reversals on Valsalva maneuver, that means there is a reflux. Color can also change, but I usually do it with the uh, power Doppler. So once you see that reversal of flow on the power Doppler, then in deep system, you require the reflux for 1 second. And for superficial system, it should be more than 0.5 seconds. Then you call it significant reflux. So if significant reflux is, best patients are those who have significant reflux in the superficial system and no reflux in the deep system. They will really benefit from the procedure that you do. So when you do your treatment of varicose veins, you can divide it into surgery and endovascular treatment. So